We're live, I hope. I'm always told we're live. You just never know. Thank you for tuning into Healthcare Triage live. Were we? I don't think we were live. Were we live last week? We were not live last week. That's right, because I had to travel. So no live last week. I think we will try again for next week. Thank you for tuning in. We've had, actually, with the exception of one of our videos, which we think got screwed up a little bit by the launch of YouTube. Traffic's been up a lot recently. We really do appreciate that. So we appreciate your watching, sharing the videos, and everything that comes with that. Keep tuning in on Mondays. We got a lot of good episodes coming up in the near future, and news is always exciting, although I can't predict that because news is always whatever's going on this week. Usual housekeeping, we'd love for you to check out our Facebook page, facebook.com/healthcaretriage. We would like for you to continue to check out, I don't know what's going on here. I'm just going to keep talking. Keep on checking out the Reddit site, patreon.com/healthcaretriage. We appreciate any support that you can give us in terms of Patreon as well. And with that, let's begin, because I don't want to waste your time. First question comes to us from Inorganic Vegan. Should I go to a doctor on a regular appointment basis or only when I feel bad? I don't have a lot of money. Okay, so if you have health insurance in the United States, first of all, I don't know if you're in the United States or not. Let's assume you're in the United States. These days, most preventive care requires no money if you have health insurance. That's one of the things with the Affordable Care Act. So much of a preventive care is now 100% covered with no copays. So hopefully money shouldn't be the reason that you're not getting it, especially if you have Medicaid or if you don't have a lot of money and you have Medicaid. If you're a state with the Medicaid expansion, that should make it even easier to go get care without much in the way of copays. Now, of course, if you are on the low end of the socioeconomic spectrum and you live in a state without a Medicaid expansion, it's very possible you don't have health insurance, and then this is a legitimate question for which there isn't an easy solution. So, Mike, the answer I give you is dependent on a few things: your age, your health, and your gender. Because women often need to go to the doctor every year for pelvic exams and things that men don't necessarily need as much. Ideally, you should go to the doctor every year for a preventive visit, but if you are a male and a young adult in your young 20s or 30s, the need for it goes way down. There's not much in preventive care that occurs in the doctor's office that you couldn't do. They will, of course, do some checking of your lungs and your heart, which is good, but the risks are really low. They could do a check for testicular exam, to see if there's any testicular cancer, but you can do self-exams for that as well. And so there's less of a reason, although I wouldn't say that there's no reason. And certainly by the time you get to an age where you're talking about doing colonoscopies or anything else that occurs, then you do need a doctor, and you should be going every year. If you're a child, you should be going at least every year to the doctor, because there's a lot of preventive visits that occur. You need to get your vaccines, you need to get a lot of things checked, you need your sports physicals, things like that. So if you're still in school, you're going to need to go to the doctor because you're going to need to get a lot of things signed. So again, if I was recapping, and again, I'm never giving out medical advice. You should always talk to your doctor. The short answer is if you are a woman and you need to have a pelvic exam every year, you probably should be going to the doctor every year at least. And if you're a male who's a small child or a young adult or even an older male, you should be going to the doctor every year. The argument and debate would occur perhaps if you're a male in your 20s or young 30s without any medical problems. The need for a regular physical goes down, although I wouldn't say it goes to zero. Matthew Peterson, is there any good research into the actual causes of kidney stones? I've tried looking it up, and the answers I get on the web are always kind of vague. Well, that's likely because there are many kinds of kidney stones, and what causes each one is different. Some are more hereditary, some are more based on diet, some are more based on things that you otherwise might do in other parts of your health, and all of those things are different based on the type of kidney stone. So it is very difficult to say what causes kidney stones like that, because the answer will always differ. Certain kidney stones are more diet-based. Certain kidney stones can be prevented by drinking a lot of water. Other kidney stones cannot. And so you would need to ask me what causes a certain type of kidney stone for me to give you a very specific answer. And I'm willing to wager if you go to the website you've been looking at and you looked at the specific types of kidney stones, you would get a more concrete answer. So that is part of why I think you're having difficulty. Diva Cassandra 1, what's the difference in the treatment of fibromyalgia and osteoarthritis? What is the overlap? All right. So those are two different things that unfortunately have a lot of overlapping symptoms. Joint pain pain in general. Those are probably most of the overlapping syndromes you're going to get. I guess perhaps some fatigue, but a pain, and especially in the joints, is where the overlap is going to be. But the causes are very different. The osteoarthritis is much more well understood in the sense that it could be autoimmune or degenerative or bone or joint related. Fibromyalgia would lack those symptoms, otherwise it would be lack those findings, otherwise it would be osteoarthritis. Fibromyalgia is much more of a collection of symptoms where we don't understand necessarily what the cause is. However, treatment is often going to be the same because treatment for both is trying to overcome the symptoms. We're often not curing the osteoarthritis so much as we're trying to provide relief. And that's why you might try exercise, you might try pain meds, you might try physical therapy before you actually got down to surgery, which, as we've talked about in previous episodes, doesn't really work so well often anyway. For fibromyalgia, it's often going to be the same. It's going to be exercise, it's going to be pain meds, it's going to be physical therapy. Fibromyalgia, they also might try to treat more globally because sometimes they will treat that with antidepressants or other global treatments that necessarily probably wouldn't show up in osteoarthritis. And so that will be the differences. And then osteoarthritis will be much more focused on trying to overcome the pain and symptoms in the joint. Fibromyalgia will add in perhaps therapy that's trying to overcome some global issues as well. But in both cases, because we're treating symptoms, there will be some similarities. Next, Xylus1, thank you for what you do, sir, and you're welcome. What keeps you in academia knowing that you can earn much more in private practice? Is the difference in pay scale between physicians and surgeons justified? Well, this is always it's a question that I get all the time, and it's like, I don't think many people choose a job solely based on income. If they did, then as you say, no one would become a pediatrician versus a surgeon. I became a pediatrician versus a surgeon because I wanted to be a pediatrician, and I didn't enjoy being a surgeon. My dad's retired. He's a surgeon, or he was a surgeon. I don't want his job. I don't want a lot of other jobs that pay really well. I want to do this job. Why do I stay in academia, even knowing that I can make more in private practice? Because I love my job. That's why I do it. I like doing research. I like teaching. I like the education. I like the freedom in my schedule that lets me do this right now. And a lot of those are part of the academic career as opposed to being in private practice. Also, there are many aspects of private practice I don't like. I don't love the clinical aspects of pediatrics as much as many of the others. I do some clinical work, but it's a small part of my job. In private practice, it would be the entirety of my job. I don't like taking call. I don't like working weekends necessarily as much. I like having more freedom over my, control over my schedule. All of those are more perks of being in an academic career. I love giving talks. I love interacting with other researchers. I love talking about science. Those are other things that are more of an academic job. And I do that because that's what I want to do, and that's what you should do. You should do what you enjoy. And obviously, financial aspects will be part of the equation, but they are not all of the equation. And you have to weigh those considerations when you choose a job. Not everyone will get that or understand it, but I love my job. I love it. That was not always the case. I just was talking with a friend recently. I know too many people who, work to make enough money so that then they can do the things that they love. I feel very privileged in that my work is, to some extent, doing the stuff that I love. I'd rather do that. But everybody makes their own choices. Ross Kennedy, my wife had obstetric cholestasis during her first pregnancy. Is there anything she can do that would reduce the likelihood of recurrence if she were to get pregnant again? You're asking me to give you medical advice, and I really don't want to do that. You should talk to your OB, and your OB will tell you what to do. It's possible, I think, that they might recommend drugs and or dietary changes, which might help with that. But you should talk to your doctor and not an internet guy. Even if that internet guy is a doctor. I'm still a pediatrician. Talk to your obstetrician gynecologist. You have one. They delivered the baby, right? Go talk to them. And this, again, isn't getting back to lifestyle. It's not about money. It's not because I'm not getting paid to do that. I just think you're better off talking to your own physician and having a relationship in that question. Terry Forprez, my GP sells a brand... Okay, sorry. My GP sells a brand of supplements and markets them to his own patients. Oh my God, we were talking about this just a few minutes ago. I would love to see the bottle. If you could please tell us his name, or like his picture is on the bottle. That would be awesome. But anyway, your GP sells a brand of supplements and markets them to his own patients. Am I biased by our mutual distrust of supplements, or does this strike you as inappropriate too? So this is inappropriate even getting beyond supplements, most likely. So first of all, yes. Is he making the supplements? I mean, it's just there's no regulation. As you know, I'm very distrustful of the supplement market. This would make me distrustful from that respect. But even more so, there's a wealth of medical research and literature that says that when physicians have ownership in some part of the medical care, there are extreme financial conflicts of interest that show up. That if a doctor owns a radiology center or as part of it, they are much more likely to refer to get scans than they would be if they didn't. If they own part of the hospital, they're much more likely to admit to that hospital. Financial conflicts of interest, which we've done episodes on, and you should watch those, are absolutely real. There's a reason 10-cent coupons exist, because they work, and that's a small financial driver. Owning a supplement company is a financial driver, and it would be very much a conflict of interest to own something and then say, I'm going to write prescriptions or tell my patients to take it. I would be extremely skeptical of that. And in fact, there are usually legal and or ethical barriers put up to prohibit that kind of ownership in various aspects of practice. Now, it may be that because supplements are so unregulated that there aren't the legal barriers for a supplement company, but like if they owned, again, the imaging center or then there would be huge firewalls that we put up so that they couldn't be responsible for fun. I mean, that's almost kickbacks. You're basically writing prescriptions for care and then recouping the money on the back end. People go to jail for that. Maybe there aren't legal barriers in terms of supplements, but all the other barriers and issues exist. I would be very skeptical. Evan Jeske, are there any long-term effects of taking the maximum daily dose of NSAIDs or ibuprofen every day for multiple consecutive weeks? Yeah. Yes. First of all, there are the known side effects such as GI problems and eventually bleeding. And those are a real concern. Doesn't mean you're going to get it, but there's a chance, and that's why we don't actually recommend long-term maximum daily dosing of NSAIDs. Plus, there's been a growing body of literature talking, and this is less in randomized controlled trials and more in cohort studies, but more associations between NSAID use and other cardiovascular issues and everything as well. I'm less convinced of the reality of that because it's associations and not causal, but NSAIDs, for the most part, have been studied well for short-term usage. Long-term maximum daily dosage is not usually recommended. I would talk to your doctor if you are doing that, because there's probably other better options for you. You should talk to your doctor. Hold Maid, whose name I recognize from before, so thank you for coming back to the program. Are there any? Why is a low body fat percentage considered less healthy for women than for men? And what are the health consequences of having a body fat percentage which is lower than recommended? So, lower is relative, and so it's not necessarily unhealthy to have a lower body fat percent, being a woman than a male. It depends on where your starting point is. We all want to get to sort of what we would consider to be a normal or healthy body weight. But when you get below that, it is true that men and women have different reactions. Some of the reactions that are seen in women have to do with hormonal cycles and hormones, because the amount of body fat that you have can actually start interfering with normal hormonal cycles. You notice that more often with women because, of course, they have very noticeable hormonal cycles with menstrual cycle and other things, and even with pregnancy. We're having a low body fat percentage when it gets abnormally low can actually start to screw up with the menstrual cycle. And that is noticeable in women. And men, you would not notice those kinds of things as easily. However, it's not good for either sex to have an incredibly low or too low body fat percentage. You're meant to have some fat. You're not trying to get to zero. Human beings are supposed to have a greater than 0 percentage of body fat. You want to stay in the healthy range. Talk to your doctor about what that healthy range is for you. But I think, again, you're just noticing it more in women than men, but I would be concerned in either men or women getting too far down in the percentage of body fat that they have. Brendan Byrne, can binge drinking once a week as a teenager and young adult affect your health later in life? Well, the flip answer, of course, is the biggest concern of binge drinking, especially in youth, is that you'll do something stupid. You'll get in a car, you'll have an accident, you'll fall. Accidents like that do occur all the time. So you can absolutely do damage to yourself because you've been drinking too much, even in the short term. There are always the stories every year of the college student who gets drunk, falls downstairs, and breaks his or her neck. You don't want that to happen. So binge drinking is probably never good. If you're asking me if you binge drink a few times as a young adult, if that's going to give you cirrhosis of the liver later in life, again, it's a volume game. The more you do it, the more likely there is to be long-term health consequences. I'd say probably most people who, perhaps did too much binge drinking in college but then stopped and didn't do it for the rest of their life, probably aren't going to have the cirrhosis that is going to happen. Because, if you stop it and you monitor your health and everything else, it's unlikely that occurs. If you stop drinking, if you stop doing it, it does help your long term. So it's not like if you do it a couple times, you've screwed yourself forever, but it is dose related. And the more you do it, the more likely there is for damage to occur. But hear me when I say again that when you binge drink or blackout drink at any time, it can have immediate consequences because of poor decision making that will occur or something else that occurs. So that's a good enough reason not to do it even now. The McLexy. I can't find a primary care physician. Every time I'm sick, doctors in my area say you must already be an established patient to be seen. How do I become an established patient? You got to go for primary care. So can you not find a primary care physician because you don't want to pay for it, like the first person who asked, or is it because there are none available in your area that are taking new patients? Those are two different problems. If it's the former, go to a visit. You got to go to a primary care visit to establish a relationship that you can go when you're sick. If it's the latter, if it's that your primary care doctor is not accepting new patients, so I'll give you some concrete advice. One, keep trying. Because even when docs say they're not accepting new patients, sometimes they do if you are persistent. The second is, do you know a doctor? Any kind of doctor? Do you know a medical student? Because some of the people sitting in this very room get their primary care physician by asking me, and I recommend and say, I got a friend, they'll get you in even if he's not. My pediatrician for my children, I think, is one of the best pediatricians, hands down, ever seen. She's amazing. Everything I am not when you're talking about a pediatrician. And she says she's not accepting new patients, but sometimes if you call and you ask nicely and you're a doctor, you can get people in. Sometimes knowing someone on the inside, is that a satisfying or fair answer? No. But you guys keep asking me this question, so I'm trying to give you concrete advice. So I would say use your social game. Talk to a doctor. Talk to a doctor that knows a doctor. Try to find a way to get in to see the doctor that you want to see. They're all human beings, and sometimes you can make it work. History Meg 83. Some friends of mine have posted about water bottles left in a hot car cause breast cancer. Any evidence for it? No. There's really no good linked evidence to show that is. Now, of course, what people will do is they will show you lots of evidence that, oh my God, we can detect certain chemicals in slightly higher quantities in the water bottle left in the hot car. And other studies show that megadoses of that chemical can lead to changes that other studies show those changes can lead to cancer. And that's all done in rats. And so they will say, therefore, it's causal. It's not in the sense that we know. Tons and tons of things and tons and tons and tons of things are linked to cancer. They're all being weighed. However, why are people so obsessed with the water bottles? I just saw an article in the Washington Post that water bottle sales are at an all-time high and that it's become the replacement for soda. And good, I'm glad you're drinking water instead of soda. That's great. But, this stuff comes free in taps or almost free. Why do you need to carry around your water in such a way that you could leave it in the car and it can get super hot, in which case you're never going to drink it anyway? What was the point? Are you thirsty? Get a glass, go to the sink, fill it up and drink it. It'll be colder. Put some ice in it even, right when you need it. Drink when you're thirsty. I just wrote a piece in the New York Times on on like why everyone is, I don't understand why everyone is so obsessed with being dehydrated. This whole 8 glasses of water thing, it's a myth. We're absolutely going to cover that in a future episode. But this is one of those where I wouldn't be terribly concerned about the water bottle left in the hot car causing breast cancer, but I would be looking at you like, why do you keep it? Why do you need it? Just don't even use the plastic water bottle at all. It's better for the environment, and there's just no need to spend a couple bucks on something that comes out of the tap for pennies. I just don't get it. Sean Johnson, is there strong evidence for a causal link between whole grains and heart health? If so, what is it about them? Is it the fiber, the various micronutrients? So again, we're talking about cohort data. People that eat fiber and whole grains are less likely or associated to have a less chance of lower cancer. Part of that is likely the fiber. Part of that is likely it's a replacement part of the diet, perhaps, or something more unhealthy. And part of that is probably just because there's something about people who are obsessed with whole grains tend to be healthier in general. This is not one of those where I'd say, go out and start consuming whole grains, which are carbs, in huge quantities because it'll help your heart. I don't know. Going by my diet recommendations, which is another good episode, you should watch that one. I tend to favor unprocessed foods over processed foods. Therefore, I probably consume more whole grains than refined grains. But I'm not looking out for grains. Like I just don't go searching them out. It's a part of my diet, but not a huge part of my diet. Fiber's great. It's good. Keeps you regular. It's also been associated with heart health. It's such a weird term, but so be it. So it's one of those where I'd say if you're going to consume grains, yeah, go with the whole grains, but don't go like taking it like medicine that you need whole grains to be heart healthy. There you go. James Craver, what research has been done on misphonia? Are there any effective treatments or therapies? I'm pretty sure that I don't know a lot about the research on misphonia, but I know that the research that I have seen sort of proves that it exists. And the people who have it have more of an auditory trigger than a visual trigger. And so the idea that there are certain sounds which just set you off in a rage there's some science and research to show that that's real. I don't know about the effective treatments or therapies. I imagine they're out there. I'd also imagine they're probably more therapy-based than medical-based, but I don't know for sure. It's a great question. If you nag me on Twitter, I will try and look it up. Andrew Hart. One of the fear against coffee is that we see people get addicted and say they can't function without it. They build tolerance and end up drinking 8+ cups a day. Is this a real thing? Well, again, you should watch my episode on coffee. I also wrote a piece in the New York Times that was based on that one as well. So coffee gets a bad rap where everybody's first of all, even if you're drinking 8 cups of coffee a day, there really aren't that many negative health consequences associated with it, and potentially some good ones. So it's like, that's a lot, I think. But, drinking coffee every day is not a terrible thing. Like, there just isn't a lot of bad evidence for it. It's a lot of anecdotal stuff, and that's not really there. So, do people build a tolerance to the caffeine? I suppose, but, then drink decaf. I don't know. And they say they can't function without it. I'm not sure how much of that is real and how much of that is just people saying it. Because I say that sometimes, but then there are days I don't have coffee and the world spins on its axis, and it's not like people at work are like, what happened to you? And so I don't know about that. But this idea that you got to fear coffee, there's just not a lot of good. That was the whole point of the article and the healthcare triage episode. There's very, very, very little evidence that coffee is dangerous, and a huge amount of cohort study and epidemiologic evidence that says it might be good. And so I'd get over it. But this is like all beverages other than water. Don't drink it because you have to. Drink it because you want to. If you don't want to drink coffee and you're afraid of it, so be it. I'm not going to push it on you. But if you do want to drink it, I wouldn't be so scared. There's really nothing to fear. I think it's delicious. And I like it. And I drink like a cup of this size every day, pretty much. Not because I have to, but because I want to. And if you want to as well, that's totally fine. Gakilb, why is there very limited poor studies in acupuncture? There aren't. There's a huge amount of research on acupuncture. It's one of the few. In fact, we taped an episode today where I think I even mentioned it. We did an episode on conventional versus alternative medicine, which you'll see in a couple weeks. And there have been not only randomized controlled trials of acupuncture, but enough that there can be meta-analyses of randomized controlled trial on acupuncture for certain conditions. And in some things, it seems to work more than others. For chronic pain, it seems to work. For many other things, it does not seem to work. There are Cochrane reviews on acupuncture. So I will disagree with the premise of your question. Why are there not studies? There are studies. You should go look them up. They exist. Tom Liger, how bad are the effects of occasional cigar smoking? Depends again on what you mean by occasional. If you're talking a couple times a year, once every few months, there's probably very few. If you're talking about occasional, meaning like all the time, weekly, well then there are probably after effects. It's going to raise the risk of mouth cancers, and you're not inhaling it, so you don't see as much as the lung problems, but tongue, throat cancer is a real thing. But again, it depends on the amount. Every once in a while, probably not that big a deal. I mean, everything again is risks and balances, risks and harms and good and bad sides. If if you enjoy a cigar a couple times a year, it's probably not going to affect your risk of getting cancer versus many, 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 many other things that you can probably control. On the other hand, if you're trying to keep your risks to zero and you don't enjoy the cigar, then don't smoke the cigar. But it's all going to weigh in that occasional, how often you're doing it. Byron Taryn, what are your thoughts on using antibiotics for something other than critical care, i.e. skin care? Well, if you have a skin infection, you should use antibiotics. If you're talking about preventive, then that's silly. There's no study at all that says that using like antibiotic soap is a great thing. That's why they are taking out the antibacterial components out of all the soaps. But there's lots of things. When you cut yourself and you're worried about infection, using like Neosporin or an antibacterial ointment has been shown in randomized controlled trials to improve wound healing and reduce the risk of infection and make better scar. That's a use. That's totally viable. That makes sense. But using it for things where it's not proven to work is silly, and you shouldn't do that. Final question. Just checking my clock. Perfect timing. Joanne Duffy, do you know anything about Alzheimer's and Down syndrome patients? My aunt has Downs and is 58 and is in the early stages. What's to be expected? I'm going to be honest with you. I don't know much about this. If for no other reason than, first of all, I think it's amazing and awesome that your aunt has Downs and is 58. But that has to make her one of the oldest people with Down syndrome that I've heard of. It's amazingly great that people with Downs are living such long lives now, but that's a relatively new thing. And so the fact that now Downs patients are transitioning to adult care and actually getting the geriatrics care is new for all of us. And so we're going to be learning alongside many of the patients that are unfortunately suffering. I don't actually know if Down syndrome is more or less likely in Down syndrome patients because, again, there just aren't huge cohorts of people who have made it to old age to study. And I can't really tell you what to expect, whether it will be worse than normal, better than normal. Alzheimer's is terrible in general. I wish I had more information. I'd love to hear more about this. In fact, you made me want to go look this up because I don't actually know. We even talk about the fact that getting Downs patients to older age getting cystic fibrosis. We're seeing all kinds of new things that we just hadn't seen in the past because people didn't live long enough. And it's awesome. It's great that they are, but now there's a whole new set of issues that people are going to have to deal with. This will be one of them. And so I'll go look it up. Tweet at me again. Remind me. I'll go see if I can find anything in the research literature on any studies that have been done. And that, I think, will do it. Again, if you can, patreon.com/healthcaretriage. We just did a podcast with them. We were one of the featured patrons of the month recently. You could go listen to that. But we appreciate all the support. We're continuing to be overwhelmed by it. And if you can, whatever, $1 a month, whatever you can do, we'll take it. It helps to make the show better. It helps us do stuff like this and make new sets, and we want to go do new stuff. And it'd be great if you can support the show. Keep watching Friday news episodes, Monday healthcare triage episodes. We got a couple of new episodes coming up I'm very excited about. We keep pumping out new stuff. That's good. Wednesday live show. We will be here next week. So tune in at 11:30. I think Stan might not be here, so it's Mark and I flying by the seat of our pants with Sharon's help, hopefully. And I think that does it. Facebook.com/healthcare triage. You can check out our Facebook page as well. Thanks for tuning in. We'll see you next week.